Hi, welcome to our SHARE webinar, Understanding and Treating HER2 Positive Breast Cancer. We'll be waiting just a minute or two as a few people get logged in. I know it can sometimes take a minute or two to get the software for the GoToWebinar started, so we're just going to wait just a minute before we begin the presentation. For those who are just joining, welcome. We're just going to wait another minute for folks to get logged on. Okay, so we're going to get started. Welcome to the SHARE webinar, Understanding and Treating HER2-Positive Breast Cancer. I'm Stephanie Blaufar. I'll be hosting here at SHARE today. Before we begin the presentation, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that improves the lives of women affected by breast or ovarian cancer through experienced peer support, accessible education, and innovative outreach, and always for free. SHARE meets women wherever they are, and especially in medically underserved communities, with the insight of women who have been there too, creating a nationwide network where women are empowered and feel less alone. SHARE's free services include support groups, educational tools, expert-led webinars like this one, a national helpline, online communities, and survivor patient navigation. For more information, visit our website, sharecancersupport.org. All participants will be muted during the presentation. When the presenter finishes speaking, we will open up for question and answer session. You're welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar will be recorded and will be available on the SHARE website soon. So today we have Dr. Rena Callahan with us. She is a board-certified hematologist-oncologist and is an assistant clinical professor of medicine at the David Geffen School of Medicine at UCLA. She is actively involved in breast cancer research and treatment. She is interested in evolving treatment of breast cancer and how complementary therapies like meditation, yoga, and Reiki can be integrated with Western evidence-based medicine. So without further ado, I would like to welcome Dr. Callahan.
All right, thank you so much for that kind introduction, and thank you so much for having me today. It's really my pleasure to speak about this really exciting and evolving area of breast cancer research and treatment. So let's see what we can get through. There's a lot of it, and I can't wait to hear your questions at the end. So the learning objectives for this talk are for you to be able to define the different subtypes of breast cancer, to define what HER2-positive breast cancer is, and then we'll review HER2-directed treatments used in the neoadjuvant, so pre-surgical, adjuvant, post-surgical, and metastatic settings. I'd like you to have a better understanding of how we assess for risk of relapse, and we'll review the importance of brain metastasis in this disease and hopefully get to be able to review some new therapeutic agents that are in development. So this painting describes our treatment approach to breast cancer 125 years ago, which was basically cut it out. This painting was by Thomas Akins. It's of the Agnew Clinic and hung in the halls of the University of Pennsylvania, which is where I did my medical school training. And so I walked by it, and you can see here there's this exalted surgeon performing a mastectomy in the round. But our new approach to breast cancer is much more than that surgical approach and involves various providers, physicians, radiologists, pathologists, oncologists, obviously, and we all work together to provide a treatment plan that takes into consideration the whole patient, much like on TV. So our treatment approach 20 years ago was local regional treatments. So those are treatments that deal with the breast and the surrounding lymph nodes and would include surgery and radiation, as well as systemic treatments, which include things like chemotherapy, tamoxifen, agents that go throughout the bloodstream. Now, the primary purpose of local regional treatments is to prevent breast cancer from coming back in the breast and the surrounding area, but it's really the systemic treatments that are used to prevent and treat breast cancer that has spread to other parts of the body, which is what is really life-threatening. A new classification for breast cancer emerged in about 2000. A group out of Stanford, Charles Peru, had a landmark article called The Molecular Portraits of Breast Cancer, in which 65 breast tumor specimens were subjected to an analysis of their genes. And what was seen was that there was a grouping of breast cancers based on the genes that they expressed. So these groupings here are represented by different colors. Now, each color represents a subtype of breast cancer. What was more important is that it was seen that survival varied greatly based on the subtype. So there's a luminal A and luminal B subtype. Those tend to be estrogen receptor positive. There was a basal subtype, many of which were triple negative, triple being estrogen, progesterone, and HER2 negative. And then there was the HER2 positive group. And as you can see here in this analysis, the survival by subtype varied greatly. So the HER2 subtype did the worst. Now, this was before the development of HER2 targeted therapies. So we realized breast cancer is not all one disease. We have to treat the different subtypes differently to hopefully affect an improved survival. And this has made its way into the lay press. It's on the cover of magazines and medical journals alike. There are, multiple articles in newspapers about this as personalized medicine, and how we can't treat everybody the same and can't treat every tumor the same just based on the anatomy. So 20 years ago, based on organ of origin, treated based on the stage, which is how big is the tumor, are lymph nodes involved, has it spread to other parts of the body, and then evolved to treat based on what does it look like, what do these cells look like under the microscope. That's called histology. But now we're treating more based on the biology. So what are these biologic factors, these genes that are actually causing the cancer to spread? So here we see that biology trumps size. So what is a targeted therapy? Well, we're referring to therapies that specifically target tumor cells and spare normal cells. Now, in order to develop a targeted therapy, you need to be able to identify the target that's driving the malignant behavior, and then you need to be able to assess for that target in the tumor or the microenvironment. And so ideally, you get less toxic, more effective treatments. So we have to get rid of that no pain, no gain mentality. A great example of a targeted therapy for breast cancer is that of Herceptin or Trastuzumab. Now, let's discuss HER2 overexpression in breast cancer. So on a normal cell, there are 20 to 50,000 HER2 receptors. But on a HER2 positive cell, there are up to 2 million HER2 receptors. And so these receptors are proteins, and they're proteins that are encoded by genes, by the HER2 gene. And what these proteins lead to is excessive cellular division. So these cancer cells just proliferate at a very, very rapid rate and take over organs and tissues and cause all sorts of badness in that way. HER2 is overexpressed in about a quarter of breast cancers. So it's a subtype of breast cancer that accounts for 20 to 25%. Now, this gene was identified in the 80s by Dr. Dennis Slayman, who's our chairman of oncology at UCLA and my boss, and an article was published in Science. And here you see in this analysis, once again, you see that the survival, this is prior to Herceptin, of HER2 positive tumors was much worse than the HER2 negative counterparts. And even if lymph nodes were involved, HER2 positivity was a poor prognostic factor. So Herceptin is an antibody to the HER2 receptor. So you'll see the HER2 receptor here in orange. There is a part that sits on the outside of the cell membrane, so this is the breast cancer cell, and a part that sits on the inside. And Herceptin, also called Trastuzumab, is an antibody that attaches to the outside part of the receptor and shuts it down. There was a pivotal trial of using Trastuzumab added to chemotherapy in metastatic stage 4 breast cancer that was published by Dr. Slayman in the New England Journal of Medicine in 2001, which showed that response rates improved when adding Trastuzumab to chemotherapy, and so did survival. And these survival benefits are very likely underestimated because many of the patients in this trial ended up getting Herceptin after disease progression anyway, so that muddied the results a bit. Trastuzumab has really changed the natural history of HER2-positive metastatic breast cancer. So what you see here is the probability of survival on the left, on the y-axis, and the x-axis, so going vertically across the bottom, is time. The HER2-positive group in the pre-Herceptin era, so without Trastuzumab, is represented by the blue line, in which it is the worst. The HER2-positive group with Trastuzumab is represented in the orange line. So what you see here is that for stage 4 breast cancer, what was once the worst type of breast cancer became the best, with the best survival because of this targeted treatment. And many, many life years have been saved, over 190,000 life years and counting since Herceptin became widely used. It was FDA approved for metastatic stage 4 breast cancer in '98, and then was approved for non-metastatic early stage, so stage 1, 2, 3 HER2-positive breast cancer in 2005 to prevent recurrences. It has very few side effects overall on a day-to-day basis, but unfortunately it's much more effective, at least initially, when it's given with chemotherapy. So it's hard to avoid that part of the toxicity. There is an additive chemotherapy toxicity with anthracycline chemotherapy in terms of cardiac toxicity, so that has to be done carefully. This story of HER2 has been made into a Lifetime movie starring Harry Connick Jr., and you see in the bottom right is Dr. Slayman in the UCLA research labs. So how does Trastuzumab work? We talked about it a little bit. So here's that cartoon that you'd seen before. It is an antibody attaching to the outside portion of the HER2 receptor to shut down the signaling. So there's a signal that goes to the center of the breast cancer cell that basically tells it to proliferate. So it blocks the proliferation signal. It blocks the signal for a cancer cell or a tumor to form a blood supply, which is called angiogenesis. And it also has some immune mechanisms. We talk a lot about immunotherapy, and trastuzumab itself was one of the first immunotherapies in that it does trigger the immune system to fight against the cancer. This is a timeline of HER2-targeted therapy. So you see that the gene was identified in the 80s, and then trastuzumab was developed in the 90s, approved after that in the 90s, and then the 2000s for early-stage disease. And now on the right, there really has been an explosion of HER2-targeted therapies, and we will go into them in much greater detail now. So most therapies are developed in the metastatic setting first, and then if they have reasonable toxicities, are brought into the earlier stage setting to prevent recurrence. In the metastatic setting, over time, resistance typically does develop to Herceptin and chemotherapy. At that point, we have several choices. We can get a response by keeping the Herceptin going and changing the chemotherapy that it's paired with. We have the option of changing HER2-targeted agents, and we have several options now. And then we can also combine different HER2-targeted agents together. So lapatinib is another HER2-targeted agent that's used in the trastuzumab-resistant setting. It's what we call a small molecule tyrosine kinase inhibitor. It's oral, and it targets that inside portion of the HER2 receptor. And in March of 2007, FDA approved lapatinib or Tykerb in combination with an oral chemotherapy called Xeloda for patients who had Herceptin and experienced disease progression. So there's this thought that dual targeting of the HER2 receptor may have enhanced efficacy. So we talked about how the trastuzumab or Herceptin works on the outside portion that you'll see here with the green upside down Y. And then the lapatinib, the small molecule, can cross the cell membrane and work on the inside. There was a study that looked at this in patients with HER2-positive advanced breast cancer that had multiple prior therapies, were either given the lapatinib alone, or Tykerb, versus the lapatinib plus the trastuzumab. And what was seen is that the response rate was greater and overall survival also improved. And that's pretty hard to prove in a setting of patients who have had so many prior therapies, 5, 6 prior therapies. Moving on to pertuzumab, which is also called Perjeta. So we talked about Herceptin. Trastuzumab works on the outside portion of the receptor. So does pertuzumab, but it attaches to a different part of the HER2 receptor. In order for this HER2 signal to multiply to get to the center of the cell, HER2 has to pair with another HER2 receptor or another HER family receptor, and that's called dimerization. And pertuzumab shuts down this dimerization, and it works in conjunction with trastuzumab. The benefit of adding pertuzumab to Herceptin and chemotherapy was shown in the Cleopatra trial. So patients were either given docetaxel, which is also called Taxotere, with Herceptin and placebo versus docetaxel plus pertuzumab and trastuzumab. This is for metastatic disease. And what was seen was a dramatic improvement in overall survival when pertuzumab was added. And so it earned FDA approval in June of 2012. What was also seen is that it was very, very well tolerated, so it really didn't add a whole lot of toxicity. The next HER2-targeted therapy is TDM1, which is now called Kadcyla, and it used to be called adotrastuzumab emtansine. It's a really interesting drug. You have the Herceptin antibody, and it's attached with a linker to a chemotherapy. Okay, so this chemotherapy, M-tansine, was initially developed at the National Cancer Institute in the early 70s, and it was so toxic that it didn't even make its way out of phase 1 clinical trials and was shelved for many years. But then it was discovered that it could be attached to Trastuzumab, and the Trastuzumab would target the chemotherapy to the HER2 positive cell, and only after it attached, it got to the HER2 positive cell, was the chemotherapy then internalized by the cancer cell. So it basically works like a smart bomb. It was tested in a large phase 3 trial and compared with capecitabine, which is that Xeloda oral chemotherapy, plus lapatinib, Tykerb, in the Amelia study. And it was shown to improve overall survival over the lapatinib and capecitabine. But what was also very important that was seen is that it was just much better tolerated. So here we have an example of something that is more effective and better tolerated. And as a result, earned FDA approval in 2013. So early stage HER2 positive breast cancer, we talked about drug development and therapies being first approved in metastatic HER2 positive breast cancer and then being tested in early stage HER2 positive breast cancer. So Trastuzumab was an example of this. So we first saw that it worked, it improved survival in the metastatic setting, and it was very well tolerated, didn't add a whole lot of toxicity to chemotherapy. So it was looked at in combination with chemotherapy to use after surgery to prevent recurrences, and it did a great job doing that. And these were 3 trials, large trials, that showed that and led to the approval of this drug. And here you see in chart form what I had described earlier, which was what happened in the metastatic setting, where it used to be the worst kind of breast cancer, but now HER2 positive breast cancer with Trastuzumab across a variety of studies has shown the best survival rates compared to HER2 negative counterparts. And so this was a slide that you saw earlier where the HER2 positive did the worst, and now here you see in the early stage setting that HER2 positive breast cancer with Trastuzumab is represented by the green line and has the best survival. So what about small HER2 positive tumors? Well, unfortunately, there is no patient with HER2 positive breast cancer that's truly at very low risk. And so this is a great example of how biology trumps size. There was an analysis that looked at risk of recurrence for lymph node negative HER2 positive tumors less than a centimeter out of MD Anderson. And what was seen that both recurrence-free survival and distant recurrence-free survival, so that means spread far away from the breast, right, to the liver, to the bones, etc., was much worse for these very small HER2 positive tumors that did not get Herceptin. So it was shown that Trastuzumab, the good news is that it benefits small HER2 positive tumors just the same as it would larger HER2 positive tumors. So now we use Herceptin even for small HER2 positive tumors. Now less than a millimeter, generally we don't. Up to 5 millimeters, sometimes we do, more often when estrogen receptor negative. And basically, for tumors greater than 5 millimeters, most of us do treat with Herceptin and chemotherapy after surgery. We also use HER2-directed therapies and chemotherapy a great deal in the neoadjuvant or pre-surgical setting. So why would we do that? Why would we give chemotherapy prior to surgery? Well, we saw that in a large trial that there's no difference in survival if you compare patients who had chemo before or after surgery. Okay, so waiting until surgery does not provide any type of survival decrement. Sometimes you can shrink a large tumor, so you may increase the chances that a patient can have breast-conserving surgery as opposed to a mastectomy. But probably the most important is that you get an in vivo assessment, so an in-body assessment of how your chemo and Herceptin is working. Because if you've done the surgery first, you are operating blind. You're giving the therapy, and you know whether it worked if you've waited time and you don't see a recurrence. Whereas if you give it neoadjuvantly, you can see the tumor shrink before your eyes. And this is used as a research tool as well, and gets drugs to patients sooner. There was an analysis proving this concept where 13,000 patients were looked at that were in 12 randomized controlled trials. And all of these patients received chemotherapy and were followed for at least 3 years. And this is a listing of those trials. And they were evaluated for survival, so event-free survival and overall survival, as well as pathologic complete response. So what pathologic complete response is it's complete disappearance of tumor after at the time of surgery. So these tumors had been administered chemotherapy, and then if all the tumor was dead at the time of surgery, that was called a pathologic complete response. And what you see here is that pathologic complete response is a surrogate marker for survival. And pathologic complete response rates vary greatly by tumor subtypes. So you're more likely to get a complete response in triple-negative breast cancers as well as HER2-positive breast cancers, because these are ones that are more chemosensitive. Remember, in these trials, all the patients received chemotherapy. But this underscores that the type of treatment that's given for certain subtypes doesn't work as well in others, like the low-grade hormone receptor-positive breast cancers that probably don't even need chemo. So pathologic complete response is a surrogate for survival, especially for these subtypes, HER2 positive and triple negative, and more so in the HER2 positive hormone receptor negative group. So Perjeta was approved for neoadjuvant, so pre-surgical treatment of early stage breast cancer, as a result of multiple trials which showed that the pathologic complete response rate improved when you added it to chemotherapy. So we talked about giving HER2-directed therapy prior to surgery, after surgery, and what we're doing after surgery has been changing a lot over the past few years. Perjeta was approved in combination with Herceptin and chemo for adjuvant post-surgical use based on the Affinity trial. So in this trial, patients went through their surgery and then had chemotherapy plus Trastuzumab or chemotherapy plus Trastuzumab plus Pertuzumab, Perjeta. And what was seen was a small benefit. It's a statistically significant benefit, but it is small, 90.6% versus 92.3%. And this is, patients had to receive the Perjeta for a year, basically, as opposed to Herceptin. So it adds on infusion time and inconvenience to the patients. So we're trying to figure out who really benefits the most from adding the Pertuzumab. Well, the higher risk group. So this is where stage matters more. So in the node-negative group, there is a smaller benefit than with the node-positive, and especially patients that have 4 or more positive lymph nodes. There is also a greater benefit in patients that had preoperative chemotherapy and Herceptin that did not get that pathologic complete response. So in this way, we're able to target the group to which we give Pertuzumab with more precision. It didn't really add a whole lot of toxicity. What you can see here is that the rate of diarrhea definitely increased with the use of Pertuzumab, 9.8 versus 3.7%. But the other side effects here didn't change too much. And overall, it's well tolerated. Neratinib, or Nerlynx, is another HER2-targeted therapy that was approved recently for use after a year of HER2-directed therapy. So it's like lapatinib. It's a small molecule tyrosine kinase inhibitor, so it works on that inside portion of the HER2 receptor and has synergistic effects seen with trastuzumab. In the ExteNET trial, patients were administered neratinib, so these are pills, after they had completed a year of trastuzumab. And what was seen is that there was an improvement in survival. So this was the study design, a very clean study. Patients went through their standard of care therapy and then took a year of either placebo or neratinib and were followed for disease-free survival. And what was seen was that there was a benefit, again, fairly small, around 2.5%, if you took the whole group into consideration. But if you look at the higher risk subgroups, such as patients with more than 4 nodes or patients that did not have a pathologic complete response, there appeared to be a greater benefit. There also appeared to be a greater benefit in the hormone receptor positive subgroup. So, why is this? We don't know for sure, but maybe neratinib has effects on receptors other than HER2 and has particular potency in that estrogen receptor positive subgroup. It was approved for adjuvant treatment in July of 17, so is starting to become used more. But the major problem with it is the diarrhea. There's the diarrhea from Perjeta, but the diarrhea from neratinib is much, much greater. We looked at it, and UCLA was part of a study to look at antidiarrheal prophylaxis with neratinib. And the ExteNET trial, which you'll see in the upper left corner, did not require antidiarrheal prophylaxis and had an incidence of high-grade diarrhea. So that means, people are having 10 bowel movements a day in up to 40%, which is just not really sustainable. But you can see in the bottom right that when used with an antidiarrheal called Cholestipol, that it really made a big difference. So when I put patients on this medication, I prescribe it with the Cholestipol. So we've talked about adding HER2-directed therapies, but there has been a movement to de-escalate HER2-directed therapy when given after surgery because survival is so good that you don't want to overdo it with the toxicity that a patient has to undergo, over the course of a year, even a year or 2 years. So I'll focus on a de-escalation trial called the APT trial. So this was a single-arm study, so there was no comparison, but patients had to have tumors less than 3 centimeters in size, and most of them had tumors less than 2 centimeters that had negative lymph nodes. And rather than receiving, a more traditional regimen like Taxotere, carboplatin, and Herceptin, with or without Perjeta, they received weekly Taxol for 12 weeks and with trastuzumab, with the Herceptin, and continue the trastuzumab. So much easier to tolerate. And what was seen is that the survival was really great in this group of patients when compared to historical controls. Now, there was no direct comparison arm, so you have to take it with a grain of salt. But I think what many of us agree to is that survival is very good with trastuzumab and chemotherapy, whatever kind of chemotherapy, even if it might not be quite as good as with the higher dose chemotherapy. There have also been trials that have explored a shorter duration of trastuzumab. So right now, you get the trastuzumab for a whole year. But some of these trials are looking to see, can we give the trastuzumab for 6 months or even 9 weeks? And most of these trials, they're trying to demonstrate non-inferiority, so meaning that the 6 months is not inferior to 12 months. So that's different than saying that the 12 months is superior. It's a statistical difference. But for most of these trials, non-inferiority was not reached. They were unable to prove it. But a very recent trial called the Persephone trial was presented at our big American Society of Clinical Oncology meeting in June, and non-inferiority was demonstrated. So I think, the take-home point from this trial is that, it's not quite ready for prime time to use with every HER2-positive patient, but if somebody's really having a tough time, especially if there's any cardiotoxicity, we feel more comfortable shortening the duration of Herceptin. Now let's focus on brain metastases, which are a big problem in metastatic breast cancer, specifically HER2-positive metastatic breast cancer. So patients on average with HER2-positive breast cancer that is metastatic have, a 5-year survival from the time of diagnosis, some much, much, much longer. But from the development of brain metastases, that survival is much lower. And it affects a lot of patients. In the Adjuvant trials, there was a disproportionate CNS, central nervous system, recurrence as the first event versus others. And there's a thought that, Trastuzumab does a great job in helping people live longer and remain free of metastatic recurrence, but that it does not cross the blood-brain barrier, so does not do a great job in the brain. And in this estimation on this slide, the CNS involvement is estimated to occur in 30 to 40% of patients. I would say in my practice it's even higher because patients live so long with metastatic disease that this becomes a big enough problem that I will do surveillance MRIs for patients with HER2-positive metastatic breast cancer at least once a year, even in the absence of any neurologic symptoms. So this really represents an area of unmet need, but thankfully there have been some trials looking at agents to see whether they are able to improve brain mets and shrink brain metastases. And this is one with the drug that we just spoke about, neratinib, which is FDA approved for adjuvant, early stage disease, but it also was looked at in patients with HER2-positive breast cancer metastatic to the brain and saw a response rate of close to 50%, which is really excellent. And so as a result, it has an NCCN guideline recommendation for use in this setting, and we can typically get it covered by insurance. And we typically use it in combination with capecitabine or the Xeloda chemotherapy. In the Nefertiti trial, it was a phase 3 first-line metastatic trial in which paclitaxel was combined with either Herceptin or neratinib. And it was a really interesting observation that the incidence of central nervous system events was about half in the neratinib group. Now, it wasn't designed to look at this, so again, it has to be taken with a grain of salt, but it is definitely hypothesis generating. There are newer HER2-targeted approaches that I think we have time to go into. So let's review the 5 FDA-approved HER2-targeted agents right now. We have the Trastuzumab or Herceptin and the Pertuzumab or Perjeta that are antibodies that attach to the HER2 receptor and shut down signaling. That cancer cell proliferation signal. They are approved as neoadjuvant, as adjuvant therapies, and as HER2-targeted therapies in the metastatic setting. Then we have lapatinib and neratinib. So both of those are small molecule tyrosine kinase inhibitors that are given orally. They're pills that work on the inside portion of the HER2 receptor. Lapatinib is FDA approved for metastatic HER2-positive breast cancer, and right now neratinib only has FDA approval for early stage HER2 positive breast cancer to prevent recurrence. However, it has that NCCN recommendation for HER2 positive breast cancer brain metastases. Then we have TDM1, which is also called Kadcyla or Trastuzumab emtansine, which is that smart bomb of the Herceptin attached to chemotherapy with very few off-target effects because it's so targeted. Patients don't lose their hair. They might get a slightly lowered platelet count, but overall, for most people, very well tolerated and FDA approved for metastatic advanced breast cancer. But since the target was identified, there are multiple newer agents under study. There is Margetuximab here, which is another monoclonal antibody. So like Herceptin and Perjeta, it's an antibody. And part of that antibody is very similar to Herceptin, but there's a part of that antibody, that bottom portion, that's different, and it's optimized to have a greater immune effect. Remember, we talked about how there were immunotherapy effects of Herceptin. Well, this drug optimizes that, so it's a Herceptin, but with more of that immunotherapy component. It showed activity in the phase 1 first in human setting. So we know that it's tolerated fairly well and it's active. And we also saw responses here. So this is what's called a waterfall plot. So bars underneath that middle zero line means that the tumor is shrinking. And there were responses in 38% of these patients. It's a small study. But it was granted Fast Track FDA designation in January of 2018. So there is now a larger trial looking at it called the SOPHIA trial, in which it's being compared with Herceptin and chemotherapy. So patients either get the Margetuximab in chemotherapy or Herceptin in chemotherapy. This is an ongoing trial. DS8201 is another HER2-targeted agent under study, and it's an antibody-drug conjugate. So like the Kadcyla, the Trastuzumab emtansine, it's a HER2-directed antibody that uses a linker to be attached to a chemotherapy. So this chemotherapy is a little bit different. It's a topoisomerase inhibitor that we call it, and it's more potent than the Kadcyla even. But we have to see whether this actually translates into better patient outcomes. These are results from a phase 1 study, and we see activity. So those are the bars under that zero, the middle line. And response rates of 43%. This is really a lot in a phase 1 study because these patients have received multiple prior therapies. We see it in various HER2 positive subgroups, HER2 hormone receptor positive, hormone receptor negative. But what's interesting is you also see some activity in HER2 low. So these are patients that don't traditionally have HER2 positive breast cancer, but they have some HER2 staining in the immunohistochemistry that's done on the tumor tissue. And while the responses are not quite as high as they were for the true HER2 positive group, 30% is pretty high for these patients. So it's being looked at in that group as well. It was granted breakthrough therapy designation in August of 2017 and is now in larger trials. Tucatinib, or ONT-380, is like lapatinib, like neratinib. It's a tyrosine kinase inhibitor. It's given orally and HER2 selective. It was studied in a phase 1b trial with capecitabine or trastuzumab in HER2-positive metastatic breast cancer, and we see responses. Importantly, we see responses in the central nervous system, so CNS, in this trial upwards higher than 40%. So there are multiple additional studies to look at this agent in metastatic disease, paying special attention to brain metastases. In the earlier trials, we saw that there was a group that had prolonged progression-free survival. So, the group represented about 20% of patients, but they were able to be on this therapy for over 17 months before having to switch to another therapy. And that in this group, that having the presence of brain metastases when starting the study did not differentiate patients that had prolonged progression-free survival. So historically, we talked about how brain metastases was a negative prognostic factor, but this drug appeared to compensate for that difference. And so it was granted orphan drug approval for HER2-positive brain metastases in June of 2017. There are other novel targets for HER2-positive brain metastases. So we talked about the tucatinib and the neratinib. CDK4/6 inhibition is all the rage in estrogen receptor-positive breast cancer. So in estrogen receptor-positive metastatic breast cancer, we have 3 CDK4/6 inhibitors that are approved under the names of Ibrance, which is palbociclib, ribociclib, which is called Kisqali, and abemaciclib, which is called Verzenio, which was the most recent drug approval. So abemaciclib seems special. So while there's no proven benefit between those 3 drugs for estrogen receptor-positive metastatic breast cancer, the one that has both single agent activity, so you don't have to combine it with an estrogen blocker, and the one that crosses the blood-brain barrier the best is the abemaciclib or the Verzenio. So this is an interesting agent under study when combined with HER2-directed therapies. And so we've seen CNS responses combining this CDK4/6 inhibitor along with a HER2-targeted agent. This just lists the HER2-CLIMB study with tucatinib that is ongoing that will hopefully lead to FDA approval. These are 2 other drugs. This first one is an Ambrx drug. It's another one of these antibody drug conjugates, so the smart bombs. And then Purus Pharmaceuticals has an interesting immunotherapy, which is a monoclonal antibody like Herceptin, but it targets 2 proteins. One is HER2 and the other is an immune receptor. So in that way, hopefully really revs up the immune system in a targeted fashion to the HER2 positive cells. Just a summary. So how are we going to get there? I alluded to multiple ongoing clinical trials. Well, we know, they're good for science, but they're also good for patients. There have been analyses of patients on and off clinical trials that have shown improved survival for patients on a research study. And now, regardless of the treatment arm, now this is fraught with bias. Patients enrolling in trials are somewhat cherry-picked in that they tend to be a healthier group, but it really is hypothesis generating. Are patients on trials getting more diligent, standard of care even? So as a result of clinical trials and patient participation, I have to thank every patient that has participated in a trial and has just, given so much of her energy to advancing science, that we have changed our approach to early breast cancer in which, we've really moved away from that original slide of the exalted surgeon to one where we recognize that what will really impact survival are the systemic treatments. And thankfully, we have a whole host of HER2-directed treatments now that have improved survival. So in conclusion, HER2-positive breast cancer used to have the worst and now has the best prognosis due to Trastuzumab and other HER2-directed therapies. We continue to improve survival with these additional HER2-directed therapies. There are now some patients who need less adjuvant therapy, so de-escalation is an important area of study, and some that need more. So those are patients where we might consider adding a year of Trastuzumab or neratinib. But unfortunately, metastatic recurrences still occur and most often do lead to death from breast cancer. So there's still a lot of work that needs to be done. Thank you very much for your attention. We're now open to questions.
Great. Yes, thank you. So now we'll start the Q&A. Just please go ahead and submit questions. You can still submit questions on the question pane on the GoToWebinar software. I have to say you were very thorough, and a lot of the questions we had were answered. I have a breast cancer patient advocate with me today to help ask some questions, Kathy Hines. Do you want to start with a question?
Yes, I just have a couple of thank you again. It was really very, very clear, and you did answer a lot of our questions. I just wanted you to clarify something for me. Lapatinib, is that used in the neoadjuvant and adjuvant settings?
So lapatinib was studied in both the neoadjuvant and adjuvant setting, but hasn't demonstrated a significant benefit. So most of us, this is when combined with Herceptin and chemotherapy. So unfortunately, these trials did not, the NeoAlto and the Alto trial did not truly demonstrate a benefit. So this is not a widely used drug in those settings. We typically don't use it.
I see. And my other question is, it's not a small enough small cell therapy that would go through the blood-brain barrier?
That's a great question. There have been studies to try to see whether lapatinib could shrink brain metastases. And there was one study that showed that it didn't, but the bar was a little bit too high. They were looking for, a 20% reduction in CNS metastatic volume, and that's kind of hard to show. What appears to be happening is that the small molecule tyrosine kinase inhibitors bind to the HER2 receptor with different affinity. So basically, the neratinib is just a stronger drug, so it works better.
Okay. And one final question on my part. Besides the FISH test, do you use any other test to determine the HER2 positive receptors, to detect the HER2 positive receptors?
So yes, that is another excellent question, because HER2 testing is something that we talk about a lot. Typically, the first test that's done to determine HER2 status is called IHC, or immunohistochemistry. And what IHC is it's a stain that attaches to the HER2 protein. And a pathologist looks at the cell, the cancer cells, under the microscope and makes a subjective assessment. Does the staining go around the whole cell, in which case that's considered HER2 positive? Or does it only go around a quarter, which is considered HER2 negative or 1+? Or is it kind of halfway, which is considered equivocal? Right now, according to the College of American Pathology, if the immunohistochemistry is 0, 1+, which is considered negative, or 3+, FISH testing does not have to be done, only if it's 2+ or equivocal. That being said, the FISH testing is more accurate, considered to be more accurate, because it actually looks for extra copies of the HER2 gene. So at our institution at UCLA, we do FISH testing on all specimens and then use both the immunohistochemistry and FISH testing together to make an assessment. For example, if they're discordant, we may repeat the pathology because we really, really want to get it right.
Okay, thank you.
Okay, so we do have a couple questions that were submitted, and you still can submit questions on the question pane. So someone was wondering if you would suggest to HER2 positive metastatic breast cancer patients to ask their oncologist to do a brain MRI every year.
Yes, I would, because the number of times that I have found completely asymptomatic tiny brain metastases has been actually pretty high. And where this makes a difference is that sometimes if you wait for symptoms, you may have multiple brain metastases where now you need to do whole brain radiation, which carries greater toxicity than stereotactic or very targeted brain radiation. So I want to find the smaller asymptomatic brain metastases earlier, so we may be able to do stereotactic radiation or enroll them in a trial, say, with tucatinib or another drug like that we might not already be using.
Okay. Another question submitted was if Trastuzumab and Pertuzumab are keeping body scans stable, is it a good idea to talk to a doctor about medicines that can cross the brain barrier? So I'm not sure if this person has brain mets or not, but if you could answer in both cases.
Sure. So without brain metastases, for somebody that has gone through the chemotherapy and is now in a pretty good spot with good disease control in the body on Herceptin and Perjeta, it's recommended that just those two agents be continued, but that's where there's a role for surveillance scans. I will not add lapatinib or neratinib if everything else looks stable, just because it adds a lot of toxicity. So here's somebody that is on Herceptin and Perjeta, probably tolerating the therapy very, very well, and to add neratinib without any proof of even a tiny brain met will impair quality of life, primarily with the diarrhea, but also fatigue, rashes, other things like that.
Somebody also was saying that they were saying that they had a symptom with the Thai curve of numerous painful whiteheads. Is that a common symptom, or is that out of the norm?
Yeah, I wouldn't say it's very common, but we see it because I talked about different HER family receptors, and HER1 is also called EGFR, which is found in skin. So having skin toxicity with the small molecule tyrosine kinase inhibitors happens. Usually it's something that we can work through that doesn't continue and it's not severe. Sometimes we treat with, antibiotics or agents that are used to treat acne. But it's not the majority of patients that get them, but we do see it.
Okay. And what is the current status of new treatments for inflammatory breast cancer?
Well, with inflammatory breast cancer, still the most important part of it is what's the biology that's driving the inflammatory breast cancer. Typically with inflammatory breast cancer, you cannot go directly to surgery because the surgeon could not get clear margins. So you have to come up with some type of systemic therapy to be given prior to surgery. Now, for those breast cancers that are triple negative, we've been looking a lot at immunotherapies, and in the I-SPY trial, adding immunotherapy to chemotherapy showed a pretty dramatic improvement in response rate, but now that's being looked at in larger trials. So I would say trying to get on a trial with immunotherapy, if triple negative, would be one way to go. With the HER2 targeted agents, even for inflammatory HER2 positive breast cancer, these agents often work very, very, very well but we definitely give neoadjuvant therapy in that setting.
Okay. Another question that was submitted in advance of the presentation was, how long should an individual continue doing a 3-week regimen of Herceptin?
That is, going back to the slide where there were several studies trying to de-escalate the duration of the HER2-directed therapy, it's still the standard of care to have a year of trastuzumab. Whether you break it up and give some of it before surgery and after surgery, a year is considered the number. There was a trial that looked at 1 year versus 2 years of trastuzumab, and there was no benefit at continuing for 2 years. But right now, the 6 versus 12-month study, there was one that the Persephone that demonstrated non-inferiority, but most of them, including the FAIR study, which is a French study, which will be presented again at San Antonio this week, did not show non-inferiority. So the number's still a year.
Okay. One more question was just submitted. Why is Xeloda believed to be useful when brain mets has occurred with HER2 metastatic breast cancer?
Xeloda is on its own. We've all seen, any treating oncologist or has seen shrinking of brain metastases with Xeloda. So even when HER2 negative, I will sometimes use, so for estrogen positive metastatic breast cancer with spread to the brain, I will often use Xeloda. So I think combining Xeloda with a HER2 targeted agent that crosses the blood-brain barrier is particularly attractive because both of them have effects.
Okay. Okay, I think that's all of our questions. So I'd like to thank you so much, Dr. Callahan, for your informative program. It's just packed full of info. I'm really glad that these slides and the presentation will be up on the website so people can go back. Somebody says they have a question, so I guess we'll take one more question.
Mm-hmm.
So let's see. So is skin lesions related on hands and feet that's maybe related to Herceptin? Is this a common symptom related to Herceptin?
No, that would be very, very uncommon.
Okay.
So pretty uncommon. Everybody's seeing, you can get a drug rash with any drug, but it's uncommon.
Okay, and so do you think it's related to would you think that's related to Herceptin, or what do you think? Should she go to her oncologist to follow up?
Absolutely, and ask and see if there may be other reasons. I have seen it before, but it's a rule out other causes and possibly treat through it because Herceptin is so effective.
Okay, great. Okay, well, thank you again. And please, if everybody could take a moment to fill out the survey that will pop up at the end of the webinar, that really helps us to improve our programming. So thank you, everybody, who participated, and thank you, Kathy.
Great. Thank you so much for having me. Take care. Have a great rest of the day. All right.
Dr. Callahan.
Bye.
Bye. Thanks.